Welcome friends, this is Dr. Deptee Warikoo, HOD Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences, Dehradun. Our today's topic is mallet finger. Mallet finger is the term applied to extensor avulsion fractures or distal extensor tendon ruptures. Either one results in an inability to extend the distal interphalangeal joint of the hand. So now we will discuss about the introduction to the mallet finger. Mallet finger in sports injuries is also called as baseball finger. So here the deformity of the finger is mainly caused due to the avulsion of extensor tendon distal to the DIP joint. It is called baseball finger or hammer finger or drop finger. Here we see the disruption, bony or tendinous in both types. The injury occurs mainly in zone 1. Mallet finger injuries are named for the resulting flexion deformity of the fingertip, which resembles a mallet, or we call it as hammer. So hammer finger could also be called as mallet finger. It is common in young to middle-aged males and older females. Most frequently involves long, ring or the small fingers of the dominant hand. It is mainly caused by the disruption of extensor mechanism of the phalanx at the level of distal interphalangeal joint. They are usually due to forced flexion at the distal interphalangeal joint. So if we talk about the mechanism, it could be due to any object like ball which strikes the tip of the finger or the thumb and forcefully blends the digit. A minor force such as tucking in bed sheet or pulling a shirt may also lead mallet finger. This force tears the tendon or even pulls away a piece of bone. This results in the inability to extend the distal phalanx. What I told you just now, like pulling away a piece of bone, or we call it as a mallet fracture, this occurs when the extensor tendon also causes an avulsion of the distal phalanx. So we call it as mallet fracture. It is very less common mechanism. Its less common mechanism is a sharp or crushing type lacerations to the dorsal DIP joints. Less commonly, a forceful hyperextension injury to the DIP joints could also be seen. So first we will see the classification of the mallet finger. The mallet finger is classified by Doyle. Doyle in his classification distributed mallet finger in 4 types. Type 1 being the closed injury with or without small dorsal avulsion fractures. So when we talk about type 1 Doyle's injury, it could have a avulsion fracture or it could be without an mallet fracture. Then Doyle gave type 2 classification. Type 2 was an open injury which occurs due to laceration type of injuries. So there is a laceration which is leading to the injury to the digit. Then there is type 3 mallet finger. Here there is again same open injury, but it is not only superficial like we see in type 2. The injury is superficial, so we see only the lacerations. But in type 3, the open injury is deep, where the soft tissues have abrasions which involves the loss of the skin over it, tendon injury, or may sometime lead to stress to the bone, underlying bone. Then Doyle classified it as mallet fracture, that is type 4 injury. So what I was talking about, the mallet fracture, which mainly occurs when the extensor tendon also causes an avulsion fracture. This mallet fracture, according to Doyle, had further categories like category A, category B and category C. Category A tells us that there is distal phalanx fracture and then it is mainly seen in the children. Category B involves the fracture, the fragmental fracture It mainly involves 20 to 50% of the articular surface. This type of fracture, that is type B, is mainly seen in adults. Then we have third type of fracture, that is C, that is the fragmental fracture. It involves more than 50% of the articular surface, and again this type of fracture is seen in adults. Now let us discuss about the symptoms and signs of mallet finger. Before going into the symptoms and signs, we all know that here we are seeing the injury to the extensor tendon. The extensor tendon straightens the finger and thumb through a very complex arrangement. The extensor apparatus is a plexus of tendons with an aponeurotic sheath. So extensor tendons are located in the dorsal region of the hand and fingers. The function is mainly to extend the wrist and the fingers. So when we talk about the mallet finger, what we see, these extensor tendons are getting injured. Okay, so mainly we have to see what signs and symptoms could be there due to extensor tendon injuries, what is occurring in mallet finger. So clinical presentation always shows an inciting incident with report of traumatic cause. There will be a traumatic cause causing to this mallet finger. Initially the finger is painful and swollen around the DIP joint. When the actual tendon is ruptured, the condition can be relatively painless. If a piece of the bone is pulled off, it is normally a bit more swollen and more tender, or we could say more sore. The end of the finger is bent and cannot be straightened voluntarily. The dorsal interphalangeal joint can be straightened easily with the help of other hand, but not actively. So what we see is the finger drooping. The patient cannot straighten it actively, but has to straighten it with passive help. Finger becomes very painful, swollen and bruised. There is lack of active DIP extension, and also you could see a swan neck deformity. So what happens in swan neck deformity? There is hyperextension at the PIP joint and flexion at the DIP joint. Swan neck deformity can be due to either the tendon injuries or rheumatoid arthritis, or there are other causes also. Now talking about the diagnosis of the mallet finger. So the best way to do a diagnosis is to take an X-ray. So avulsion of the distal phalanx may be ligamentous injury with normal bony anatomy. So we will have to take an X-ray and identify about the cause of the injury and the area where the injury is occurring. We also will see with the X-ray that if there is involvement of fracture, means if there is presence of mallet fracture or not. Now the classification, there could be acute and chronic. Acute mallet finger deformities are those which occur within the 4 weeks of injury, and chronic deformities are those which are presenting later than 4 weeks. Now if we talk about the treatment, we have non-surgical and surgical treatment. The main goal of non-surgical treatment is to keep the finger straight until the tendon heals. Extension splits with DIP joint in extension for 6 to 8 weeks. Then this splint is taken at days and kept in the night for 4 additional weeks. If there is bony avulsion, then mallet splint could be used for 6 weeks. It is mainly used. Maintain free movement of the PIP joint. Begin progressive flexion exercises in the first 6 weeks. Now, what is the management of acute mallet finger injuries non-surgically? So, outcome, if about 80% of the closed injuries will heal within the 6 weeks or 8 weeks, depending what type of splintage you are using and how you are using it. If the tendon does not heal within the period of time, further splintage can be successfully used. If that also fails, then only we go for repair or surgical repair. Controversy still exists which type of splint has to be used and how it will be effective. Now, what are the indications for Surgical management. If there is volar subluxation of the distal phalanx, if large bone fragments more than 50% of articular surface is involved, or जो भी we are using non-surgical treatment is not successful, then only we will go for the surgical management of the mallet finger. Now, surgical management, we will go for closed reduction or open reduction. We could use pin fixations or dorsal extension blocking pins. Open reduction internal fixation with a pull out wire is mainly used. Surgical reconstruction of terminal tendon in chronic injury, that is where the injury has been there for more than 12 weeks with the joint being healthy, could be directly repaired with the help of tenodermodesis or reticular ligament reconstruction. This we have already seen in our tendon transplant and tendon surgeries. We could also go for Fowler's release therapy, that is the central slip release, which we have already discussed in the extensor tendon injuries. Now type 1 and type 2 can be treated closely. Type 3 which has a fracture, type 3 which has a deep injury requires a soft tissue coverage and pinning of the DIP joint. The DIP arthrodesis is also used there. If there is swan neck deformity present, then lateral band tenodesis could also be used along with the Fowler's surgery. Now again, management of the acute mallet finger injuries type 1. First we have to mobilize the DIP joint in the extension. A transarticular K wire is driven longitudinally or obliquely across the DIP joint. Here you could see it. Here. The tip of the wire is buried in the middle phalanx. Here you could see. The distal end is either capped or cut beneath the skin surface. So post-operatively, K wire is removed after 6 to 8 weeks. This is followed by a 2 week of night splinting. Night splint has to be used even in surgical management. Now if there is mallet fracture, then there are disadvantages of surgical treatment, like it is more demanding technically and there are more complications after surgical repair. A dorsal prominence overlying the DIP joint may follow non-surgical treatment, which may happen in certain cases. Now, doing a surgery in mallet finger, we have to make sure that chronic mallet fingers may develop pathological features which are being looked properly. A static contracture or the extensor mechanism can also develop over time a contracture. Also, we have to see this contracture does not develop. When we are doing a DIP arthrodesis for mallet finger, we have to make sure that it is effective, but the position of the fusion is between neutral to 10 degrees of flexion. Advantages of this type of arthrodesis is it is very helpful in pain relief, and early PIP joint motion is also happening easily in this. Then we have a tenodermodesis. So this technique uses an elliptical wedge of the skin, tendon and scar tissue which is resected. Then the skin and tendon are re-approximated as a single unit with the sutures. Similar to the surgery we see earlier. A temporary K wire is used to maintain the DIP joint in full extension. This extension is maintained throughout the healing process. There are other surgeries also which will be used for the management of the mallet finger, like the extension blocking pinning technique. This is mainly done with 3 types. Type A you can see here, with the distal phalanx extended, K wire is inserted proximal to the fragment, the fractured fragment. Second, the fracture is reduced manually, then directing the exposed end of the K wire distally. Here you can see. Then in the third, the wire is drilled into the head of the middle phalanx and the second wire is passed retrograde across the distal interphalangeal joint. There are complications after mallet finger surgeries, like we could have the patient showing extensor lag or a non-union, or some patients may also come forward with swan neck deformities. For physiotherapy management, we need high quality evidence to see which type of management we have to follow. In general, a splint will be more worthy for 6 to 8 weeks. Then exercises can commence to gradually increase the movement in tip of the finger. It usually takes around 3 to 4 weeks to regain maximal movement and strength of the finger post immobilization in mallet fingers. So other treatment therapies may include cold therapies in early stages when there is tendon injuries. We also recommend splinting, as I told you. Stretching is very helpful. Physiotherapy exercises like passive and active range of motion exercises, strengthening exercises, conditioning exercises are very helpful. Usually these techniques will result in satisfactory healing and allow the finger to extend properly. But patient education is essential to ensure that the patient understands the necessity of maintaining DIP joint extension. The key is continuous splinting for the first 6 weeks. If the splint is removed and the finger is allowed to bend, the process will be disrupted and you will have a poor prognosis. The splint must remain on it all the times, even when the patient is in shower. The splint should hold the DIP joint in full extension and allow the ends of the tendon to move as close together as possible. This is very important. In chronic mallet finger cases, splinting may still work in case these cases the splinted finger has to be kept in splint for 12 weeks to avoid drooping of the finger. Then patient re-education after that, make sure the patient returns easily to the activities of daily living. You can see the different splints. The first one is the stack splint. This is the another type of splint we use in mallet finger. This is called as aluminum splint. And the third one is the oval figure of 8 splint. Chronic mallet finger splinting is very important. I told you nearby joints may be stiff after you remove the splint. So make sure that you design a proper exercise program after that. It is very important. So these are the main exercises you will tell the patient to perform. Fisting and opening the fist. It is very important. You could use a nerve balls or grip strengthening. Picking of objects, you could use peg holes and hand rehabilitation kit. And then passive movements to the fingers. This is very important for the mallet finger rehabilitation. So make sure that all the exercises are done properly, then only you will get a better prognosis in the mallet finger cases. That was about mallet finger or baseball finger. If there are any queries, you could call me, message me or WhatsApp me. Thank you so much.